Everyone, today I will bring to you a sample of the future. Now, what are we going to do in future in our dams classes? And what we've already initiated is an integrated teaching. Now, integration means that we want you to learn that in the end you will be looking at a single patient. It will not be a pathology patient or a medicine patient or a surgery patient. You have to look at an integrated combined picture. And today, because I know many of the medical students, they struggle to understand what integration means, we will bring to you a question from DAMS question bank, and we will do an integrated discussion with you, with the medical perspective, with the pathology perspective, with the radiology perspective. We'll try to give it all to you in one discussion. And if I'm sure you will enjoy it. Do let us know in the comment section about the discussion and any other topic that you want us to discuss. With me on the panel today, we have Dr. Achin Mehra. You already know him. He's a very, very famous neurology teacher as well as a very, very fun teacher to be with. He always makes things easy for his students. And Dr. Sanjeev Chitragar, you know him. He has the idea. He is not just going to talk about pathology. He'll talk about pathogenesis of the disease and the why behind a lot of things that you see in a disease. We have selected a difficult topic today, and I'll hand over to Dr. Achin Mehra to start the proceeding without, telling the surprise to the students.
Thanks a lot, sir. We have chosen a difficult topic, you're right, sir. A topic that we often try to neglect and get across and think that it's so difficult, I should not read it. But as they say, the Stri Kalana or Nareba is not a good thing. A topic which looks as a ghost and difficult to you will come back again in this format. Okay, so let's take on a topic from hypoparathyroidism, pseudo-hypoparathyroidism, or false. Now, to understand a topic, I always feel that an MCQ should be there with us. Now, the question reads like this. A 30-year-old male came with a history of numbness and tingling sensation, that is perioral. And on general examination, patient doesn't have any kind of a skeletal abnormality. The blood investigation showed the serum calcium is low, phosphate is high, serum parathyroid hormone level is increased, and response of urinary cyclic AMP to PTH is normal, right? Now, what is the most probable diagnosis in such a case? Now, looking at the background, I've got a patient who has got hypocalcemic symptoms. He's hypocalcemic. And most important, the serum PTH is high, but the urinary cyclic AMP response to PTH is normal. That means PTH is somewhere able to generate cyclic AMP as a second messenger for its work to be done. But still we find the PTH has gone up. And most important, the calcium in the patient has gone low. Now, what is the most probable diagnosis? Is it a case of pseudo-hypoparathyroidism type 1A, type 1B? Is it a pseudo-hypoparathyroidism type 2? Or is it a pseudo-hypoparathyroidism? Now, to understand this question, we need to read a theory, a difficult thing, that is a pathogenesis of pseudo-hypoparathyroidism in this. Now, I'll request Dr. Sanjeev to come in again. And sir, it will be really nice if you explain us the pathogenesis part of this pseudo-hypoparathyroidism and various types. Where is the defect and what is the final effect of it? So over to you.
Thank you, Dr. Achin. Yes, sir, I'll make sure most of you will end up understanding the topic, one of the very difficult topic. So I have to go, right from the basic here. So I'll be talking about, the basic pathophysiology. That's the first thing. And then I'll be talking a little bit about genetics. And then I'll start integrating these a little bit into medicine. And of course, again, then Dr. Achin will take it forward from there. So, let me just start going to the parathormone action. So, I'm interested in where does the PTH work? Let me say this is your cell and this is your receptor for the parathormone, and this receptor for the parathormone that we call that is a G protein coupled receptor. So we know that it's a G protein coupled receptor. There are a variety of subunits of this. And the parathormone goes and binds to your G protein coupled receptor, and there is one called as a alpha subunit. So we need to only know about this alpha. There are alpha, beta, gamma subunits of this. So we are interested in GSA, which is also called as the alpha subunit of the protein, or G alpha S, whatever word they use doesn't matter. So this alpha subunit of this parathormone, what does it ultimately do is induce production of adenyl cyclase. So what does this adenyl cyclase do? Adenyl cyclase ultimately induces the cyclic AMP production, the CAMP. You know, you are looking at the question and there was a CAMP response to the PTH was given. Ultimately, CAMP is going to be produced by the PTH once the PTH couples with its receptor. Now, what will this CAMP do? CAMP, ultimately, we know that parathormone has action on kidney and also on bone primarily. So what does CAMP ultimately do is going to inhibit, have a negative inhibition, negative role on osteoblast. So it will have a negative osteoblastic activity, which ultimately leads to activation of osteoclasts. So when osteoclasts get activated, this will lead to calcium release from the bone. So this is what is happening in the bone. Now this CAMP also acts on kidney, that is in the renal tubules, and in the renal tubules ultimately what does it do? It leads to reabsorption of calcium, excretion of phosphate, and also vitamin D synthesis. The hydroxylation of your vitamin D also happens in the renal tubules because of this CAMP ultimately. So very important in this, we need to know this CAMP, what does it do and where is it the role. So that is one thing that we need to take from this physiology part. So now other roles of GSA. So this is what I want to know, this alpha or basically G protein receptor. We all have studied this in physiology. There are many receptors which are G protein coupled receptors. Which other hormones also act through this? So it is one is a TSH also acts through this. Then GHRH, growth hormone releasing hormone, epinephrine acts through this, and even on mesenchymal cells. So there is this alpha subunit present, or basically G protein coupled receptor are present on these all other roles, important ones we are writing. So you'll understand this subsequently. Whenever there's a mutation happening in the receptor for parathormone, that is the G protein coupled receptor, other hormones also can get affected. So now let us talk about the genetics. So this was about the basic physiology that I spoke about. Now I'm talking about the genetics here. Now we'll talk about the gene coding for the GSA. The alpha subunit of the G protein coupled receptor is called as GNAS. And GNAS is a dominant gene. What do I mean by this word dominant gene? One mutation is enough to cause the disease. The story doesn't end here. This gene expression, there is an imprinting happening in your GNAS. So what is imprinting? We already know imprinting is a physiological silencing. One copy gets silenced, either father's copy, that is paternal, or a maternal copy can get silenced physiologically, right? So gene expression, very, very important. This is a very different variety of imprinting as compared to other imprinting disorders that we have studied, like Prader-Willi and Angelman syndrome. Why? Because imprinting happens here in kidney. So in kidney, there is a paternal imprinting, not in all the tissue. Rest all tissue will not have imprinting, only kidney is having. So that means it happens, expresses only the maternal copy. So remember this, kidney expresses only the maternal copy of GS alpha or GNAS expression basically. It is also seen in a certain extent even in thyroid and pituitary, and that is why other hormone can also get affected, but primarily in the kidney. So remember this, it is primarily in the kidney. So in rest of the tissue there is no imprinting seen. So to explain this with the help of a pictorial representation, so I am showing only kidney and bone because we are talking parathormone here. So in kidney and bone, so let me say that bone and other tissues. So let me say this is red. The red gene is your maternal and the blue is your paternal gene. So which gene expresses where? We all know that in all other tissue or in kidney, we already know which copy gets imprinted is the paternal copy gets imprinted. That means which copy gets expressed? Only the mother's copy, mummy's copy in the kidney. Remember this. So kidney belongs to mummy here. That is what is happening. And in all the other tissue, both the copies are getting expressed, right? So this is basic thing you need to remember, because this is the basis of the different types of pseudohypothyroidism, pseudohypo. You'll understand based on this. So now let me take this further. What happens if this gene gets deleted? We already have understood what is this GNAS, what does it do? So it is a receptor, and we already have studied it is for parathormone receptor. Not only for parathormone, I also told it is also present on mesenchymal cells. It's also a receptor for epinephrine. It's also for GHRH and also TSH, by the way, right? So what happens if GNAS is deleted? So very important, all of them are very important here. Let us talk about this. Of course, GSA expression will be reduced in all the tissue. but the kidney expression will depend upon which copy gets deleted, for a simple reason. Why? Because kidney expression will only be reduced if maternal gets deleted, or because the active copy in the kidney is maternal. In all of them, any copy gets deleted, doesn't matter, they will reduce expression because it's a dominant gene. No, okay, now, so if GNS gets deleted, what happens in the bone? Of course, whether paternal gets deleted or maternal gets deleted, there will be no inhibition of osteoblast, because in the bone there is no problem with maternal or paternal. So if there is okay, one mesenchymal, first we are talking, so no inhibition of osteoblast in the mesenchymal cells. This can lead to heterotropic ossification. So there can be ossification happening in the skin, in the connective tissue, etc. That can happen if this is deleted. Next, one more, there will be no inhibition of osteoblast. I am talking it in the bone now. If there is no inhibition of osteoblast in the bone, so there will be more action of osteoblast. So more growth of bone will lead to early fusion of growth plate. It can lead to short stature, short bones. We'll study that later on subsequently. That is a concept here. Next, there will be no action of epinephrine, because epinephrine also uses the same receptor. That is why no lipolysis, which can further lead to obesity in this patient. There can also be reduced action of GHRH, growth hormone releasing hormone. This can ultimately lead to reduced growth or stunted growth kind of thing. So all this later on you will understand this subsequently. We call this together, the complex is Albright hereditary osteodystrophy. Basically there's an osteodystrophy happening. That is what is it, and we'll discuss this later on. Dr. Achin will discuss this clinical features, but yes, just understand the basic pathogenesis now. Now let me take further. So we were talking GNS deleted, common things will be happening. Whichever copy gets deleted, all these things can happen. Paternal or maternal, doesn't matter. Now kidney, the action on kidney will depend upon which copy is deleted. So there could be two possibilities, a maternal GNAS deletion or a paternal GNAS deletion. So now look what will happen if there's a maternal GNAS deletion. First thing, let me tell you, rest of the tissue like bone, the epinephrine action, the growth hormone action, everything else remains lost here because of the deletion that will happen. So again, let me draw back my images here. If there is a maternal deletion, what will happen? So again, let me draw those maternal copy and the paternal. The red one is the maternal and the blue one is the paternal. So if there's a maternal deletion in bone and other tissue, there will be only one gene, because it's a dominant. Only one gene means no expression. And in kidney, there will be no gene. Why? Because normal action was only what? The maternal in kidney. Whereas if there is a paternal deletion, and that means what will happen is in bone, there will be one gene which will be maternal. But however, since it is a dominant one gene deletion, there will be expression of disease from the bone. But however, in the kidney, look, if there is a paternal deletion in the kidney, kidney normally had an active maternal copy. So kidney doesn't get affected if there is a paternal GNAS deletion. That is simple to understand. So based on this, there will be slight variation in the manifestation of them. So look at this. If there is a maternal deletion, systemic disease has to happen. We already discussed this. It will happen whether maternal or paternal, doesn't matter. There will be AHO, there will be obesity. And what about maternal deletion? Kidney will be involved. That is why there will be PTH resistance in the kidney. Parathormone resistance in the kidney will be there. So patient will have AHO, obesity, resistance to PTH. That is what is simple understanding of maternal deletion. If there is a paternal deletion, what will happen? There will be systemic disease. Yes. Why? Because I already told bone will get affected. Same with the other tissues. So AHO, obesity, etc. can happen. Is kidney involved here? Answer is no, kidney is not involved here. Why? Because the active copy was on maternal copy and deletion has happened in paternal. So there will be no resistance to the PTH in the kidney. Basically, very word important, no resistance to PTH in the kidney. And that is what is the difference. These are two different diseases, we call them. The first one is PseudoHypoparathyroidism. We call this 1A type. Of course, 1 is enough, because subsequently we divide them into further types, 1A, 1B, 1C. So 1A, this is called as 1 or 1A, you can call it. And the other one, if there is a paternal deletion, we call it as PseudoHypoparathyroidism. It is a double pseudo here, pseudo-hypoparathyroidism. That is what is the two diseases. So simple maternal deletion will cause pseudo-hypoparathyroidism 1A, paternal deletion will cause pseudo-hypoparathyroidism. So let us talk what will happen to the serum calcium, phosphate, and the parathormone levels. So simple, if there is a resistance to PTH in the kidney, So there will be in the kidney there cannot be action of PTH, and we already understood what does it do: calcium reabsorption, phosphate excretion, and that is not going to happen. That is why there will be reduced calcium, increased phosphate, serum phosphate, and increase in parathormone. Why parathormone gets increased? Because there is no action of parathormone in the peripheral tissue. That is why there will be a feedback to feedback to the endocrine feedback will go. Ultimately there will be more secretion of the parathormone from the glands, right? So this is what is going to happen. And what about in paternal deletion? Since there is no resistance to PTH in the kidney, so reabsorption of calcium will be normal, excretion of phosphate will also be normal. So since PTH is acting, there will be everything will be all normal here in pseudo. Okay, so this is two important difference. One more thing, there was a thing that was given in the question also, if you remember, urinary CAMP or response to PTH. That is what we do. So basically what do we do in these things is we give PTH to the patient. When you give PTH to the patient, PTH has to go and bind to the G protein coupled receptor. Once it binds, it induces adenyl cyclase, which will ultimately produce CAMP. We have studied this. So this CAMP, which is produced in the renal tubules, can be excreted in urine as well. We test that. And also because the CAMP further can act and ultimately induces phosphaturia. In normal people, if I give you PTH will go and act on the kidney, and once it acts on the kidney, you start producing more of CAMP, and that will also be excreted in urine, and also you will produce more of phosphate that will also be excreted in urine. So there will be phosphaturia and increase in CAMP in normal response. But however, in case of PHP1A, that is pseudohypoparathyroidism 1A, what will happen? Response to PTH. Since there is block happening, there will be problem mutation in the alpha subunit of the GS. That is why there will be no production of CAMP. So urinary CAMP will be reduced. Urinary phosphate will also be reduced, for a simple understanding, because CAMP will not be produced here, right? So if you remember the first image that had shown, let me just yes, the first image that had shown, this is the one which I wanted to show you. So imagine if this is mutated, GS alpha is mutated, I give parathormone binds to the PTH receptor, but however it cannot induce CAMP. So if it cannot induce CAMP, there cannot be CAMP excretion in urine nor phosphate excretion in urine. This also doesn't happen. That is what is the test done here. Similarly, response to PTH in case of a PPHP, pseudo-hypoparathyroidism, it will be having increased CAMP and increased phosphate, which is normal, we say, right? So increase in CAMP and increase in urinary phosphate will happen here. So this is what is the basic of the two diseases, pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. So, the interesting fact doesn't just end here. Now I'm going to show further few more things that will make it more interesting, the disease more interesting, and this can come as a question also in exam. So look at this. So let me start writing with a pedigree, and let me say this fellow is a male who is having a pseudo-hypoparathyroidism 1A. And can you tell me if he's having pseudo-hypoparathyroidism 1A, that means his which copy is mutated? His maternal copy is deleted, basically, right? So he marries a normal female. Let me say he has 4 kids, and out of 4 kids, since it's a dominant, 50% will have the disease. Yes, correct. And 50% those who are having the disease, look at the color. I've changed the color here. Why do I have changed the color? Now look at this. This fellow who gets the mutation, where does he get the mutation? He gets a mutation from his father. So he will have a paternal mutation. She will also get mutation from her father, paternal. Both of them are having a paternal mutation. That is why they will have pseudo-hypoparathyroidism 1A or pseudo. They will be having pseudo-hypoparathyroidism. For a simple reason, that means will their calcium be normal? Yes. So importance of this is whenever you are investigating, since these are genetic disease, whenever you are investigating family members, if you just investigate calcium phosphate, you might end up being wrong. Why? Because you might end up having parent having a normal calcium, normal phosphate, but the child might be having a reduced calcium and increased phosphate. So you should be very careful when we are looking at this because of, so why is this happening? So look, father had pseudo-hypoparathyroidism 1A and the children are having pseudo. Now, let us talk on this side now. She's a mother. Now she got married to a normal male and she has kids. And now can you tell me again, one kid will be having disease out of 250%. What will be the disease in this child? In this child, the disease is mutation is coming from the maternal copy. That is why maternal deletion will lead to resistance in kidney. That is why this child will have again back pseudohypoparathyroidism 1A. Right. Similarly, on the other side, if there is a father who is a male who is having a pseudohypoparathyroidism, he marries and his kid will get sorry pseudohypoparathyroidism only, because again there's a paternal deletion. So if there's a maternal deletion, then there will be PHP. If there's a paternal deletion, then there'll be pseudo. So just last one, I just want to keep this. So look at this. Mother is having pseudo. What will be the child having? Child will be having pseudohypoparathyroidism, not pseudo here. Why pseudohypoparathyroidism? Because again maternal deletion is leading to this, isn't it? Yes. So this is about the difference between the pseudo and the PHP1A. Now, PHP1 types. Let us talk about this genetic types of PHP1. PHP1 is divided into 1A, 1B, and 1C. A little bit confusing, but I'll try to simplify it here. So look, what is this 1A? PHP1A is due to maternal deletion. So there is a deletion happening, and that is the maternal deletion. We already studied that. PHP1B is abnormal maternal imprinting. See, look, we were talking normally in kidney, which copy gets imprinted? Paternal gets imprinted. That is physiological. Everybody has that. Imagine you are having a physiological imprinting in the kidney, which is paternal. If you get abnormal maternal imprinting also happens in the kidney. So in all of the tissue, it is not happening, only the kidney. So if both the copies get silenced, only kidney gets affected here. Rest of the tissue will not get affected. Why? Because this is not an inherited mutation that was happening. It's the abnormal imprinting happens. Methylation abnormalities will be happening here. Next is the PHP1C. This is your maternal deletion leading to problem with the coupling of the GS alpha problem. So there is not GS alpha is not mutated, but however, coupling of the receptor is not happening there. So how do I differentiate between them? PHP1A we already studied, because there will be problem with kidney and also rest of the tissue. That's why they will have AHO, obesity, PTH resistance, even other hormone resistance like growth hormone resistance. There can be TSH resistance also happening. So that will be the manifestation of PHP1A. Now, what about PHP1B? I told you this only will affect the kidney. Why only affects the kidney? Because it is a abnormal methylation happening in maternal copy. Maternal copy should not get imprinted. Only the paternal should have been imprinted. Here, maternal also is getting imprinted. That will not affect rest of the tissue. That is why it will affect only in the kidney. PTH resistance in the kidney. Rest of the tissue will not be having any problem. So there will be no AHO, no obesity, other hormone resistance will not be there in 1B. This is how we differentiate. PHP1C, since it's a problem with coupling of the receptor, absolutely same. AHO will be there, obesity will be there. So for all practical purpose, PHP1A and 1C, actually 1C is a new terminology where there is a new mutation identified. That's the only difference between 1A and 1C. Otherwise, clinically they are same. Even the routine investigation will also be the same. Let us look at this. Serum calcium, phosphate and PTH in 1A. Serum calcium low, phosphate high, PTH will also be high. Whereas in 1B, what about this? Same thing again. Why? Because kidney is affected here also. In 1C, also exactly the same thing. So this will not differentiate between your pseudohypoparathyroidism types. Now, response to response to PTH, we are talking about urinary CMP and also the phosphate in the urine. So obviously, whenever in PHP1A, CMP will be decreased, phosphate will also be reduced. Why? Because it is not acting, right? In case of PHP1B, also CMP is decreased and phosphate is decreased again here. And PHP1C, the same thing. CMP is decreased, phosphate is decreased. So these things are not differentiating between the PHP types. What is differentiating here? Of course, 1A and 1B clinically can be differentiated, not on these routine investigation. 1A and 1C clinically can't be differentiated. On investigation also can't be differentiated. We do one more investigation. We test a in vitro activity of GS alpha receptor. Commonly, it can be done in many cells. You can do, because G protein coupled receptors are present on any cell. You can look at any cell. GS in vitro GS alpha activity is reduced because there is a mutation in the receptor itself. Whereas in PHP 1B, there is no problem with the receptor at all. So it is absolutely normal. It is just an abnormal imprinting happening in the kidney. And 1C also, it will be normal. This is the very important difference that we will do. So they will give you commonly erythrocyte JS alpha activity is normal will be PHP1C. So this is about the PHP1 types. There's one more pseudohypoparathyroidism now, that is your PHP2. What is happening in the pathogenesis of PHP2? Mostly remains unknown. We do not know exactly what is happening here. No mutation we know for this. There is no mutation of GAS or GS alpha. That means it is not inherited. It is acquired, possibly. Again, this is possibly an acquired disorder due to vitamin D deficiency. This is possible explanation. And what is happening here? There is a CAMP produced. So very, very important to know that CAMP is produced. So that means whenever parathormone binds to the receptor, CAMP will be produced, but the final action is deficient. So if at all I have to show it, what is happening in PHP2. So if you remember PHP1, the problem was here. This was your PHP1. The PHP2, the problem will be beyond this. That means the problem is somewhere here and here. So CAMP will be produced there, but there will be no action on the renal tubules. That is what is the problem in pseudohypoparathyroidism 2. So I think then further, of course, PTH resistance will be present. Other hormones will be unaffected because no problem with and no AHO features because there's no problem with the receptor itself. So serum calcium will be low, phosphate will be again same thing, high, and parathormone will be high. Response to urinary CAMP, very, very response to PTH. Urinary CAMP increases. Why? Because the receptor is normal, CAMP production will happen. So it will increase, CAMP will increase, but will phosphate get reabsorbed? Answer is, sorry, will phosphate get excreted? Answer is no, because the terminal action is lagging. So CAMP will increase, phosphate will still be low. So it is not absolutely a normal scenario here, but yes, this is what is, I've tried to club everything right from the basic physiology to the genetics and the pathogenesis of all the different types of pseudohypoparathyroidism and also the pseudohypoparathyroidism. I think this should be enough for you to make a clinical diagnosis with all the things that you are having already. And I think I'll hand it over back to Dr. Achin now. Sir, to you now. Sir, mic is, sir, your mic switch, please. Achin, sir, your mic.
Okay. Now I think so, sir. Am I audible now? Right.
Yeah. Yes, sir, you are audible.
All my doubts got very, very clear. What is the genetic mechanism of this drama of pseudo hypoparathyroidism? Okay. And just quickly rewind and revise everything with you with what Dr. Sanjeev excellently explained, that a pseudo hypoparathyroidism is a problem in the PTH receptor. The PTH receptor was supposed to act through an alpha subunit, and it is attaching to the beta and gamma subunit, and then the GDP is converting itself into GTP, and the alpha subunit dissociates itself from the beta and the gamma subunit. Now the GTP will activate the adenyl cyclase. Adenyl cyclase will produce the cyclic AMP, and then the final action of the cyclic AMP will bring out the effect of the PTH hormone. Now there is a GNS alpha deficiency that we find in this particular part of the GNAS gene, that is resulting in a pseudo hypoparathyroidism type 1. There are of two types, type 1 and 1B, 1A and 1B. The 1A has a GNS alpha deficiency. Finally, the urinary cyclic AMP generated will be less. Calcium reabsorption, of course, from the bone and reabsorption from the kidney will be poor, so hypocalcemia will be there. Phosphate, yes, will rise in the patient, and AHO phenotype will also be seen. So PHP1A is a resistance on the bone as well as the renal tissue to the parathyroid hormone, right? The second type is a 1B, which doesn't have a GNS alpha deficiency, but there is a problem in the GNAS methylation over here. We find that the urinary cyclic AMP is low, calcium is low, the cyclic, the phosphate levels are high, and of course the AHO phenotype is missing. So PHP1B or pseudohypoparathyroidism 1B is a resistance only on the renal tissue, not on the bone. So the phenotype, the HO phenotype doesn't that much develop in these patients. So the same thing again, the PTH resistance is on the proximal part of the convoluted tubule in the renal tubules only. Now there's another problem where the cyclic AMP doesn't really show its final effect. That is known as pseudohypoparathyroidism type 2. Here we find there the genus alpha deficiency is not there. Urinary cyclic AMP level is normal, but the final action of the urinary cyclic AMP on the renal tubule or any other tissue is not there. The HF phenotype is not seen in these patients because there's no problem on the bony cells. Okay. And pseudo, there is no GNS alpha deficiency. The urinary cyclic AMP level is normal. The calcium and everything is also normal, but the HO phenotype is seen. So pseudo hypoparathyroidism is a patient of a phenotype of pseudo who looks like a pseudo, but it's not a pseudo. It's a pseudo of the pseudo, known as the pseudo hypoparathyroidism, right? Now, I'll just summarize what we know as a Albright hereditary osteodystrophy. This is a typical phenotype in these patients that we find due to increased osteoblastic activity. There is early union of the epiphyseal plate somewhere, and these patients often develop a short stature. They might also have a round face. Early onset obesity is also seen as a phenotypic feature. And brachydactyly, that is a short fourth and the fifth metacarpal or the metatarsal bone. So somewhere we find in these patients, they may be a knuckle, and a dimple. That means the fourth and the fifth metatarsal and the metacarpal bone will be slightly missing in them. I'll request now Dr. Sumed to pitch into this and let us know about the radiological findings that we expect in such patients.
Thank you, Dr. Achin and Dr. Sanjeev. I think, I was just wondering that at the level that you guys were teaching, as a resident also, I would have enjoyed the entire discussion of pathogenesis and the disease process. It is, so wonderful to hear you both, talk about the disease process. So as far as radiology goes, so in radiology, in this condition, we have two important things to see. These are important as far as even if you are a resident doctor also. Are you able to see my X-ray? Yeah. Achin, are you able to see my X-ray?
Yes, sir.
Yes, sir.
Great. Okay. So, often in radiology, we say that hand of a patient tells the story. So we can, but in our classes, we always talk about hyperparathyroidism, and very less time we get to talk about hypoparathyroidism. I'm so happy that, we have the opportunity today to talk about this. So look at this hand here. And, for hyperparathyroidism, we look at the middle phalanx. For hyper, listen to me, HYPER, hyper, we look at the middle phalanx for subperiosteal resorption. But for hypoparathyroidism or pseudo-hypoparathyroidism, where we are talking about today, we look at these metacarpals. So these are short fourth and fifth metacarpal. But pseudo-hypoparathyroidism may not be the only cause of it. This metacarpal, short fourth metacarpal, is also seen in Turner syndrome. So remember that, pseudo-hypoparathyroidism, Turner syndrome, and it could be idiopathic, it could have post-infective sequelae, could lead to this. But two top things to remember here will be pseudo-hypoparathyroidism and Turner syndrome. The second thing that I wanted to show you here was, which I personally love as a question as well for exams, is basal ganglia and white matter calcification. So what happens here is that this is what is the area of your lentiform nucleus, chordate nucleus, white matter area. So you can see basal ganglia and white matter calcification. Now, why it is so important? Because you tend to forget. Normally, when we see calcification, we think of hyperparathyroidism first. But here, whenever we see basal ganglia calcification, we think of causes like pseudo-hypoparathyroidism, hypoparathyroidism, and even pseudo-hypoparathyroidism. We think about things like carbon monoxide poisoning, lead poisoning, Farr syndrome, Kokane syndrome. So these are the things like where we would think about, pseudo-hypoparathyroidism in a radiological image. And I'll request Dr. Achin and Dr. Sanjeev to take it forward. Student, the most important thing will be a spotter where they will keep an X-ray with a short fourth metacarpal, and you'll keep looking at the other things. But always look for the discrepancy. That's very important, because that can be a clue to a systemic disease. That's very important. Okay. Over to you, Dr. Achin.
Now, something as sir mentioned, there is some kind of excessive calcification also seen in these patients that we find. Okay, just correct it once. In this, that we have excessive calcification also seen that can be at other points in the body, like in the basal ganglia, as showed in the imaging, that is heterotrophic calcification. And remember, this calcification is not only in the basal ganglia, even in the skin acute, especially the palm and the sole of the feet. You can find these kind of changes of calcification known as calcinosis cutis, right? So let me summarize everything together. Like, a patient came to me with hypocalcemia and hyperphosphatemia. What are the differentials that we find? One is pseudohypoparathyroidism type 1A, where hypocalcemia, hyperphosphatemia is seen. The urinary cyclic AMP is low in these patients in response to the PTH. The PTH level is high because there is PTH resistance. The GNAS alpha deficiency is seen on the bone and the kidney, so the AHO phenotype is present there. And of course, there is a resistance to the PTH seen in them. So that a typical case of pseudo hypoparathyroidism calls out the most common type of it, that is PHP1A. 1B is hypocalcemia, hyperphosphatemia is seen, urinary cyclic AMP is low, PTH level is high, GNAS alpha deficiency is absent. The AHO phenotype is not seen in these patients, and the resistance is only present on the renal tubule. Remember this. PHP type 2, if you remember, the hypercalcemia is seen in them, the urinary cyclic AMP is normal, the PTH level is high, GS alpha deficiency is not seen, AHO phenotype is not seen, and even there is no resistance to PTH. So what we have here is the urinary cyclic AMP, the final effect of the cyclic AMP on the target tissue is not seen in them. That is the only problem that results in a hypocalcemic situation in them. And we find that there's a problem who looks like a pseudo, but it is not a pseudo. Yes, that's a case of pseudo hypoparathyroidism, where the only thing that they have is a AHO phenotype with a GS alpha deficiency, but there is no resistance to the PTH. So as Sanjeev said something about the paternal imprinting that somewhere happens here. Let us read the question again. A 30-year-old male came with a history of numbness and tingling from the perioral area. General examination, there is no skeletal abnormality. There is no AHO phenotype. Calcium is low, PTH is high. And the response to urinary cyclic AMP to the PTH is normal. Got it? So that means the cyclic AMP is well enough produced here, but it is unable to finally act on the target tissue maybe. And now the problem comes of hypercalcemia. And then so the final answer is pseudo hypoparathyroidism type 2. Okay, so if I had written a small jingle or a nursery rhyme on this, yes, pseudo, yes, papa, PTH resistance, no, papa, hypocalcemia, yes, papa, oh, no, papa, show me your phenotype, ha, 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 short phenotype, okay, so something, one day he will make his father very proud, okay. Case of pseudo, who looks like a pseudo.
I think it was a wonderful, summary of the entire disease process that we saw. And I would also now like to take a word from both of you, as teachers, and you have been students in your own time. So this is a question that we have taken from DAMS question bank. So are you happy with the depth of the questions and the quality of the clinical vignettes that we have in the DAMS question bank today? So Sanjeev, your take on it first.
Sir, DAMS question bank currently is the best one that I see in the market. For a simple reason, I would say, the same questions don't get repeated here. So, there's a concept and we move on to the next concept, and that is how it is there. I see most of the questions in the DAMS question bank. Rather than having 10,000 questions and repeating the same thing with, accept, not true, same, true, false, accept. Those things are not there. So this gives you a ideal way that it will test all your knowledge in a quickest short span of time. And the clinical vignette, I think we are the only one who are giving this clinical vignette question bank. And as of now, we are having thousands of questions already added to that. And by end of this year, there will be few more, many more will be added. And just look at the question here. The question that Dr. Achin took was also a lot of integrated one, and that's what is going to be the future of the questions as well. I hope students are enjoying all these sessions, and of course, DAMS question bank and other things that we are giving. And yes, as Sir said already, please leave in a comment about how you feel about such sessions, and any suggestion you want to give us, or topics or something which we can take further in an integrated manner.
And Dr. Achin, any advice to students who are preparing for this year's NEET PG, the exam is getting delayed, or people who are preparing for upcoming exams or the exit exam? How should they utilize the DQB?
Yes, sir. They should utilize the DQB to get a sense of the real exam, first of all. Because remember this, the questions are not going to get repeated. Even the DQB question won't be there in the NEET or any other exam. If someone claims that my question came in the final exam, is just bluffing on this. So remember this, the question never gets repeated. It is a topic gets repeated. So after reading a DQB or a clinical vignette, you will have an insight of what to read and what to leave at the end. Because and I used to prepare in DAMS as a student long back in 2005. I remember these kind of clinical vignettes used to come at that era, and suddenly the examining body got changed. The thing became one liner. It was more of a memory based thing rather than a knowledge based thing. But now the time has, for the last 1 or 2 years, has really changed. Now they are more getting questions on clinical things, which you need to just find the keyword in a particular question and arrive at the approach and at best answer. So these kind of clinical vignettes and DQB questions can help you to improve the approach to solve an MCQ. And my final request to every student is that if you see a tough topic, don't try to postpone it. Don't say nale ba or kal ana, because if you try to postpone it, that ghost will come and attack you in the exam. And then you will feel guilty. Arey yaar, it was such a simple topic like pseudohypoparathyroidism. I should have read it once and finished it off there only. So kill all the ghosts around you so that you don't get scared in the exam finally.
And that is the key. I think, Dr. Achin has told that whenever you see a tough question, don't run away from it. Don't say isko baad mein dekhenge, usko tabhi dekhna hai. And that is the key to improving your MCQ skills. Karenge aur milke karenge, together we will win. I wish you all the best. And do let us know in the comment section if you are enjoying the clinical case series going on the DAMS Daily YouTube channel nowadays. Thank you.